Today, our first speaker is Dr. Candice Chen. Dr. Chen is an associate professor in the Fatu Mullen Institute for Health Workforce Equity in the Millikan School of Dental Public Health. Candice is the chair of the board of directors of Beyond Flexner Alliance, and her presentation is titled Social Mission, the Role of Health Workforce in Addressing Health Equity. Please join me in giving Dr. Chen a warm welcome today.
Okay, wonderful. Well, thank you. I am so excited to be here, and should probably also reveal part of the reason I think I might be here, and actually why I'm so excited to be here is because for a couple of years I ran the Division of Medicine and Dentistry at HRSA and was actually there when Dr. Capelli's HRSA grant was awarded. It was from about 2014 to 2018. I spent 4 years there, and I have to tell you, I think I spent a lot of those 4 years simply learning about the dental workforce, the oral health workforce, the issues in oral health. Some of the programs that we managed were the pre- and postdoctoral training grant programs, as well as the state oral health workforce program. And I know that there are at least a couple people here who are grantees of the state oral health workforce. So one, I should probably just thank all of you for providing me that education and giving me the opportunity to engage then and now. So what I'm going to talk today about is probably a lot informed by my time at HRSA. I am a physician by background. I'm a pediatrician and have spent a good amount of my career basically studying the health workforce, and particularly the role of health professions education are in the case of medical schools or residency programs, in the case of oral health, dental schools, dental hygiene programs, as well as residency programs in dentistry. So let me see if my slides will work. Okay, and so what I'm here to talk about today, and I am also maybe a little bit more height challenged than I thought I was going to be here, but I think if I step away, you won't be able to hear me, so I'm going to stick with the mic. What I'm here today is to talk about health workforce equity, and I am from the Fatu Mullen Institute for Health Workforce Equity, and one of the kind things that Dr. Capelli and Annalise suggested, I will say, and are allowing me to do is talk a little bit more about Fatu Mullen, who our institute is named after, who passed away right after Thanksgiving this past year. It hasn't even been 2 months yet, and a lot of the work that we do, the work that I'm going to talk about, is really based on about 55-year career that he had in advancing health equity and in looking at workforce issues to advance health equity. I think he started, and I'm going to show you a couple of slides, when the term health equity didn't really exist. And because I think of some of the work that he and others, I actually think in this room, have done, now we're willing to say the words health equity. Where even I think 10 years ago, as we were doing some of the work that we were starting to do back then, I'm going to show you today. One of my earlier lessons in working in this field was this. About 10 to 15 years ago, if you were to say the word social mission or health equity, while the doors might not literally slam in your face, it did feel like doors were slamming in your face. And the really exciting thing is this is now about 10 to 15 years later, the issues of health equity are rising, and we're able to gather in a room and talk about these issues of health equity. So really exciting things, but I think it's really important also to recognize where and the work that came before us. Fatu Mullen, if you don't know who he is, led a long career in health equity, health workforce leadership. He was a physician by background. He led the National Health Service Corps. He led the Bureau of Health Professions, which is the bureau inside of which the Division of Medicine and Dentistry, the oral health training programs, the state oral health workforce programs were all developed and live today. He was a former Secretary of Health for the state of New Mexico. He was an Assistant Surgeon General. He was a prolific writer in medicine. He wrote a book called White Coat, Clenched Fist, which remains an anthem for medical activism. And he had a career of advising around the Clinton healthcare reform, advising around the Affordable Care Act. Around the Affordable Care Act, some of the advising actually turned into drafting of legislation that was incorporated into the Affordable Care Act. I was lucky enough to happen to be working with him at that time, and we were able to go up and both meet with staffers around the Affordable Care Act, as well as draft some legislation that turned into the Teaching Health Center graduate medical education program that aims to train primary care physicians as well as dentists in community health centers that exists today, as well as a National Healthcare Workforce Commission that was established but not funded, and really kind of points out the need that we have at the national, state, local levels to really workforce plan, and to build that planning off of data and analysis. And like I said, that one passed in legislation, but it wasn't actually funded, has never actually been established as a commission. But he did all of those things, but in his more recent years, turned a lot of his focus in his writing and in his research towards this issue of health professions education and the role that health professions education, our schools, play in producing a workforce that's really meeting the needs of our country. And so some of those things that I'm going to show you today. But where I start is actually, if any of you knew Fitz, he was a prolific writer, and about a week before he passed, I was CC'd on an email of his last piece that he sent to Academic Medicine, and this was mid-November. And he wrote this one last piece that he sent to Academic Medicine that actually published last week. And so what I'm actually doing is pulling a couple of his words. I'm not going to read them to you because you can read them, but in the summer of 1965, between his first and second year of medical school, he describes feeling disillusioned. Right? Why did he go to medical school? He had spent 1 year in medical school, and it wasn't what he was expecting. It wasn't, it didn't kind of fill the reason that the mission that drew him to medicine in the first place. And feeling a little disillusioned, he went down to Mississippi as a medical civil rights worker, and spent the summer doing everything from public health kind of initiatives, trying to get people and work with the public and medical healthcare systems to address equity issues, and in this case, in the context of civil rights, to just straight up being a civil rights worker in Mississippi, and working to get people signed up for newly integrated schools, supporting people, standing in front of a church in the middle of the night. And he describes to protect it from firebombing, and he describes all of that both in a little bit in this paper that just published in Academic Medicine and other places. And he came back from that summer recognizing that what he wanted to be was what he called a civil rights doctor. Well, I think that the civil rights doctor is really the precursor to the health equity warrior that we actually look to build and to support today. People who will be able to address the issues of health inequity, we'll say health disparities, and champion and have the skills to be able to address those issues. And actually I sit here and I kind of, after meeting a couple of people this morning, dental director from the state of Mississippi, I know you're out there somewhere, and the dental director from Montana, yesterday from Rhode Island, from San Diego. What I kind of recognize is that I think that you all do it, and you do the hard work, and you are also the existing, I will say, workforce in terms of health equity champions and health equity warriors. I actually love the question this morning of how many of you on a day-to-day basis are doing health equity work, and I have to admit, given the list of who you are, I actually expected many more of you to say, every day I am doing health equity work, because I think every day as a public health person, you are doing health equity work, particularly if you're working for government. But he, after that summer, recognized this is what he wants to do. And I always love starting with this because it's just such a reminder of how long people have been doing health equity work, really, and the kind of groundwork that people laid so that we can do what we do today, to talk about what we are together to talk about today. And he also highlighted this, in this paper, he highlights this issue of people, and I believe this, I think he believed this. Actually, last night I was having a conversation with Dr. Evans, and I think he said almost the exact same thing about dental schools. Why do people go into healthcare, into public health, into healthcare? I believe that people still go into these fields because they're mission-driven, right? And now there's all this evidence that what we do to people when we put them through medical school, when we put them through dental school, is we kind of drive that mission out of them, right? And it's like we're slowly killing that thing inside of so many people. And I suspect that many of you are where you are in somewhat reaction to that, right? Looking for meaning, looking for ways to stay with mission, right? And a little bit of what we are now struggling with is how do we do that on a much broader level? And so what is health workforce equity? This is a slide that I don't expect anybody to read the little fine little details of. It's not really meant for that. What I use this slide for is because sometimes when we use the words health workforce, people are kind of like, huh, what are you talking about? And oftentimes people think, oh, well, it's about counting. It's about counting the numbers of different people and different kinds of healthcare workers. And if they're pretty advanced, they will think beyond physicians, dentists, and nurses. And they'll start thinking about things like medical assistants and dental hygienists and starting to think about things like community health workers, right? But beyond that, it is also about things like where do people go? Who do they serve? Even if they're located in certain communities, are they serving high-need communities? Right? And oftentimes people will think about that in terms of health workforce. I'll tell you, we take a much, much more expansive view of health workforce. And one of the things I always say when I start talking about health workforce is there's a thing that I think people naturally understand, which is there is no healthcare without people. We still cannot deliver any kind of healthcare without people, and that's what workforce is. That's what health workforce is. It's about the people who deliver health workforce. And so it is about the decisions that people make in terms of the specialties that they go into. It's about the decisions that people make in terms of where they're willing to go, Montana, Western Montana. It's about the decisions that people make in terms of the populations they take care of. In the oral health arena, we find it very, very hard to track people just by location. There's the question of whether or not they take Medicaid. And wherever they're located, whether and how much Medicaid service they provide. And that's a real challenge. And recognizing that there are absolutely what I call practice side issues. There are payment issues that drive those decisions, right? And those are high-level policy issues. But there are other issues that drive those decisions as well. And one of the things I always like to remember is that in terms of the health workforce, in terms of our professions, right, that there is a lot more than just federal and government policy. That what defines a profession oftentimes is self-regulation. And so that there's work to be done in both areas. When we talk about policy, there's both the public policy, I'll say, as well as the private policy. And particularly in some of our higher level health professions, there's a lot of private regulation and private the way that our accreditation works, the certification that really is driving how people practice, where people go, what they choose, how they practice. In terms of how they practice, workforce is also about, on a one-on-one basis, the decisions that people are making in terms of what they do for their patients, right? One of the things that we're really starting to uncover and start to struggle with is the issues of unconscious bias. When we look at maternity outcomes, right? What's driving those? Some of what's driving that is the one-on-one issues, right? And I might even be generous by saying it's unconscious bias, right? There is literally discrimination embedded in individuals and within our systems, and people are starting to struggle with that. So that's a workforce issue. Around that particular issue, and any issue that it involves an individual, is the issue of what does your team look like around you, right? What's the culture of the team? How is the team put together? How does the team work together? Around that is the system, the organization. We'll start with the organization and the policies and the culture of the organization. Around that is the system. Around that is our policies. And so that's how we approach health workforce, is from every single level talking about how do those policies drive individual practice, as well as burnout. and issues that ultimately are going to affect both the healthcare worker as well as the delivery of healthcare, access, quality, cost, efficiency, right? And that quadruple aim, now burnout, that kind of underlies all of those things. The other thing that we really do think about is not only in practice, but in the education and training sphere, right? And how does education and training then drive what it is that people will do? And again, that is everything from the professions that they choose. It is everything from whether they're willing to go and practice in rural or underserved communities, whether they're willing to take Medicaid patients, right? And we know that things inside of education and training drive those things. The things that Dr. Capelli, the programs, those training programs make a huge difference. Where we train makes a huge difference, right? Who we recruit makes a huge difference in those issues. And that is actually where I'm going to, I think, go from here. Well, actually, I'm going to show you a couple of things first, just to kind of like set us together on some of the health workforce challenges that we really face as a nation and as local communities, states, and local communities. And I suspect things that you all see really on a day-to-day basis and maybe struggling with, so you probably understand this much, much better. This is a map just from HRSA, from the National Center, actually it's from HRSA. It's looking at the health professional shortage areas. This one is particularly primary care and primary care health professional shortage areas. And I always just show this because it's always just so striking to me how much anything that's green or any color green is considered a health professional shortage area, primary care health professional shortage area in the United States. And I always just show this because it's always just so striking to me how much of the country is covered by green here. And I guess in this situation, green is not good. And the more green it is, the higher or the kind of worse off the health professional shortage area is. And then in some workforce projections done by the National Center for Health Workforce Analysis, they do project that by 2025, we will have a primary care physician shortage of, it says, almost 24,000. So they project a primary care physician shortage of almost 24,000, and you kind of look at our current, and that does take into account current health professional shortage areas. But then a really interesting thing that report did was it projected that we were going to have an oversupply of nurse practitioners and physician assistants, which seems interesting, right? Given the fact that we have that what they're projecting is a shortage of primary care physicians. And I do have to say, this report did come out while I was at HRSA, and I have to say that I thought it was very brave of them, given some of the professional jockeying that still goes on in this area of scope of practice for nurse practitioners and for physician assistants as well. One of the things that the National Center pointed out is that if we could do a better job integrating nurse practitioners, and not replacing, but integrating and building teams that are high-functioning primary care teams, then we might not have any primary care shortage at all in the United States in 2025. Right? So that's just something to think about. One of the other things I always say, though, is let's not just believe that primary care is a big issue. And so or just because I show you primary care shortage areas, you go, yes, obviously we have primary care issues. This is just a relatively recent study that came out. A lot of the primary care workforce research has been done comparing the United States to other countries, but as many people notice, in the United States, we don't always believe those kinds of studies when we're being compared to other countries, and there's a lot of reasons that we are different than other countries. But this one was looking at the U.S. population, and it was looking at primary care to population ratios, and what it showed is that the primary care to population ratio is actually associated with life expectancy. And that higher, I think the thing is that, let me see, every 10 additional primary care physician per 100,000 population is associated with a little over 50-day increase in life expectancy. So it's kind of like the holy grail of outcomes, right? Like literally mortality. And when they looked using population data across the United States, across counties in the United States, what they found is that the primary care per population ratio is literally associated with the length of life, mortality. Specialty as well. Specialty physicians, every increase in 10 specialist physician per 100,000 population leads to a 19-day increase in life expectancy. So both, but for specialists, maybe not quite as much as primary care. And what those maps are actually showing you, though, is change over time. Everything that's blue is an area that lost primary care physicians per population over time. Everything that is kind of that yellow-green gained primary care physicians. On the left side, it's primary care physicians. On the right side, it's specialty physicians. Right, and so that's from 2005 to 2015. And given the association to life expectancy, it's concerning how blue the right, or now I keep switching sides, but how blue the primary care map is compared to the specialty physician map, right? So it sounds like it matters. This is the dental health professional shortage area map. Not quite as filled in terms of health professional shortage areas as the primary care HPSA map, but a lot of the United States is covered by what we would consider dental health professional shortage areas. And we could have lots of questions as to whether health professional shortage areas are good, are the right way to measure, and things like that. And there's lots of debate around that. But I think, well, and you could probably tell me better than these maps could tell me of whether or not these are true, and whether the challenges that communities face in accessing oral health care. And one of the things that the National Center also pointed out in the oral health workforce projections was that if we could use our dental hygienists more effectively, that would significantly mitigate the dental health professional shortage areas. And obviously dental therapists is another rising issue inside of the oral health workforce. Some more specific numbers, rural health workforce, just to show you a little bit more. We have real challenges in distribution and access in rural communities. And I know a lot of you are probably if you're from a state, I'm pretty sure almost all of your states have some rural communities that you're probably paying attention to, some more than others. In the physician workforce, we have a real challenge, 13 physicians per 10,000 versus 31 physicians per 10,000. And what it shows you on the very far right is the ratio. So a real disparity in the number of physicians in rural communities versus in urban communities. And there's potentially issues on both sides. Just because you see the urban ratio doesn't mean that the urban ratio is right. One of the real things that we're starting to struggle with in the physician workforce is overtreatment, and whether supply is driving unnecessary demand, right? And whether that's causing harm, right? So really complex issues embedded in some numbers that look pretty simple, right? Physician assistants are on there, a little bit more prevalent, more present in rural communities. Registered nurses are a little bit more evenly distributed between rural and urban communities. That probably has a little to do with how we train our registered nurses and the importance of things like community colleges there. Dentists. Dentists look about like physician assistants, but there is still this disparity between rural communities and urban communities. Psychologists. Mental health is a big issue, and we have a real disparity in terms of psychologists and the availability of psychologists in rural communities versus in urban communities. And there's any number of different approaches to how people are starting to look at these issues. With psychologists and with mental health in particular, I think people are really excited about telehealth and whether the psychologist or the mental health provider actually needs to be physically present, which then brings up issues of rural IT infrastructure in rural communities, and starts turning us to think about different issues and different challenges, and how do you start implementing some of these not simple solutions to not simple issues and problems. So workforce diversity. We have a real ongoing challenge with workforce diversity. And again, what I show you on the very top level, what I show you is the US U.S. diversity overall, the population diversity in 2018, and that's from census. And then what you see is, again, physicians, physician assistants, registered nurses, dentists, and psychologists. And in each of the different professions, there's places where some are better than others. There's almost nobody who looks very much like the U.S. population. And this is a real issue. It's a real issue for a number of reasons. One of the reasons that people are always really interested in diversity is because there's issues of concordance between patients and with their providers, culture and cultural concordance, and the ability to provide culturally competent care. There's also a small body of evidence that suggests when we have diversity in the workforce and in our training, that regardless of what your race ethnicity is, that you come out on the other side a little bit more culturally competent, which seems to kind of make sense as well. So there are issues of, and what I would also say is that we also know that when we recruit and admit from certain populations, people from rural backgrounds are more likely to go back and practice in rural communities. People from disadvantaged backgrounds are more likely to serve disadvantaged populations, right? That people bring in certain characteristics. And in medicine, we have a real challenge because, oh goodness, something like 2/3 of our medical students come from the top, and I'm going to get these numbers all wrong now, but basically from the top tiers of socioeconomic status. So we have a real problem, and it starts all the way from the point of recruitment and admissions, but even that, in front of that, if any of you are doing pipeline programs, right, one of the things that we know is that access and opportunity for these kinds of health professions is different for students and people coming from different kinds of backgrounds, right? And so if we're going to address diversity, we need to do that probably as early as early education, maybe even earlier, right? I know a lot of you think about life course, right? And the other thing I always say about diversity is yes, it absolutely is important for issues of access. It absolutely is important for issues of quality of care when we think about cultural competence and some of the other issues that we're uncovering inside of healthcare these days. But it's also very much an equity issue for the healthcare providers themselves, right? That these professions are labor opportunity, right? And so who we're making education available to is an equity issue for the people inside of our workforce. We're also starting to think about equity issues for various members of our healthcare, and there's that question of what's our responsibility in this case. One of the places where we really see this rising is in some of our frontline workers, medical assistants, certified nursing assistants, and the fact that these are important jobs. They're important jobs for the delivery of healthcare, but they're also important jobs for people who are seeking jobs, right? And again, labor opportunity. And what we're seeing is such interesting, oftentimes disturbing things of education and certification programs that are charging medical assistants to go through a certification program so that they can get that first job, right? But that first job is often going to be a minimum wage job, right? And so putting debt onto an individual who's really looking at a minimum wage job. And from healthcare side, they're also a highly needed workforce. And so in terms of healthcare workforce, this is another area where we're starting to really to move into, is to think about what is our role here, not only to meet the needs of healthcare organizations and healthcare delivery, but to meet the needs of the individuals who are going to fill those positions, right? To address equity for those workers. And so I'm going to turn a little bit now, let me just look at my time, to this issue of social mission, because I think in the agenda, it starts with social mission. And so you might be like, what is social mission? And what I wanted to show you is some work, when we talk, well, let me go back first. Oh, well, I won't go back too far. And I'll show you the big framework again, but in that education and training sphere, right, that there are things that are medical schools, that are dental schools, that are health professional training programs, that are nursing schools, can do to influence whether people choose certain professions, certain specialties, choose to work in rural and underserved areas. The evidence clearly shows that there are things that they can do, that it's about role modeling, that it's about training in community health center settings, for example, about training in underserved communities, right? The evidence is pretty strong that when you do those things and when you do them well, people are more likely to go practice in underserved areas, right? In some ways, it's almost, it shouldn't be mind-blowing, right? It's like common sense. A lot of this stuff sometimes is common sense, but it's always nice to have the evidence to support that it actually does work, right? This is a paper that we did, and we published it in 2010. And what it did is it looked specifically at medical schools, and it looked at what we called the social mission of medical schools. And basically, we looked at every single medical school in the United States, both osteopathic and allopathic medical schools, and we looked at 3 major outcomes. Some pretty straightforward outcomes, given the ongoing issues that we've had in medicine, in physician workforce, in terms of specialty distribution, in terms of primary care, in terms of underserved areas, in terms of diversity. And that's all we looked at. We looked at the outcomes in those 3 areas. We said for each medical school for a 3-year period, how many of your graduates actually went in and stayed in after residency primary care? What percentage went into health professional shortage areas? Well, what did the diversity of your classes look like? And this was led by Fitz, had the audacity, I would say, to bundle it all together into a single score and rank all of the medical schools in the United States. And not surprisingly, and I know this is really little, and you'll have this, and you're not meant to be able to read this because it is very, very little. But basically, if anybody has heard of the U.S. News and World Report rankings, this turned the U.S. News and World Report rankings upside down. Right? On the bottom, you probably can't see it, but on the bottom, I'm showing you the bottom 20 and the top, well, actually the top 10. But in the bottom 20 are a lot of medical schools whose names you've probably heard of before. Hopkins, Stanford, Duke, Columbia. Very well-known medical schools, right? And what we showed is that there was a real difference between the production of primary care physicians, the production of physicians that go into underserved communities, right? And that some of those very, very well-known medical schools that people talk about and that rank very, very well in the U.S. News and World Report were not producing the physicians that the nation and states and local communities really need, right? But on the flip side, there were medical schools that were. With the diversity component, 1, 2, and 3 were Morehouse, Meharry, and Howard, are historically black colleges and universities with medical schools, right? Not surprising and deserved because they're mission-driven medical schools, right? They have a very specific mission for diversity, right? But then other medical schools that you might not spend a lot of time thinking about, Wright State University, University of Kansas, University of South Alabama, right? These were the medical schools in 2010 that we showed were doing the hard work. And as dental public health people, I think you probably understand that issue of doing the hard work, right? These were the people who were doing the hard work and producing a workforce that kind of stood in the face of every other pressure that there is in terms of the payment side, as well as the culture of healthcare and medicine, right? And it got a bit of a reaction from the community. To flip that ranking upside down and got a little bit of attention. And it was meant to do that, right? It was meant to show people that you can and should be looking at these kinds of outcomes. And we should be asking that question of, in this case of medical schools, of what are you producing that is meeting the needs of the nation? And how are you accountable for that, right? And so what's happened as a result of that? Like I said, I think one of the really wonderful things about this paper is not only did it show that some of the big name ones weren't necessarily producing the workforce that is really, really highly needed in the United States, but that there are medical schools that are doing it and there are people that are doing it, right? There are people that that are holding on to mission, that are actually translating mission to the next generation, right? Again, in the face of kind of every other pressure that is pushing people in different ways, right? And what it uncovered for us is that there are people that are doing it, and that there are people inside of some of these other organizations that are trying to do it, and that there needs to be a community and an opportunity for people to come together, a place where people can start talking about issues like social mission and health equity, right? And what happened as a result, one of the things that came out of this study was something called the Beyond Flexner Alliance. And in recognition of the fact that there are a number of, and it started with medical schools, but it's now grown into a movement that is beyond medical schools. I think that we've actually had our most success moving with nursing partners as well as with dental partners. And the Beyond Flexner Alliance is basically a movement, an organization, a community where people can come together to do a couple of things. One is to share the innovations and the work that they're doing, very similar to the work that you're doing, right? And to find like-minded people and find new ideas, right? I'll tell you, one of my real frustrations at HRSA was the going away of something called the all-grantee meetings, right? Because there's this real issue, and that's why I think that meetings like this are really important as well. There's this real issue of the only thing that gets published are successes. But if you're about to start a new program, don't you want to know where others struggled, what didn't work for others? Right? And so there's a really important need to be able to come together in spaces like this and to be able to share those issues, to discuss the challenges, and to get together on how do we start to address some of those challenges together as a community, right? The policy issues, right? And so the Beyond Flexner Alliance is about that. It's about sharing best resources as well as best practices, innovations, resources, as well as bringing people together to identify the challenges and the places that we need to advocate and work together to start to address some of the health workforce equity issues, some of the policies, both private and public policies, that are continuing to support inequities and disparities in our system. And I do have one final slide if you're interested in the Beyond Flexner, which is we're holding our big conference in April, and it's a great place to come together to do that. And the other thing is something called the Social Mission Metrics Initiative. And this is something that went into the field this past year. Dr. Evans actually has been an advisor on it, which was, there's this issue of being able to say, oh my goodness, I didn't realize that my graduates weren't, that I look so, well, not so poor, that compared to others, I was putting out so few people into rural and underserved areas. And then the next step is well, why? What is it that I'm as a medical school or a dental school or a nursing school doing that is getting these kinds of results? And so the Social Mission Metrics Initiative is it's a pretty large survey. It takes something like 7 or 8 hours to complete, and it's our kind of starting round at it. But basically what it does is it's a self-assessment tool for nursing, dental, and medical schools to be able to look at themselves and look at the things that they do in order to ask themselves, oh gosh, does my mission statement address what we call a community of need, right? I don't know if you've seen mission statements that say, we are going to produce in medical schools it's often the physicians for the world, versus we're going to produce the physicians for Southern Illinois, right? It's a very different mission and a very different approach. And that's what the Social Mission Metrics Initiative, all through various components of what these health professions training programs do. It pushes the organizations to look at different components of themselves. And then what it does is by bringing all the information in, we actually send out a report to all of the schools that complete it to say, this is how you compare to the other schools, right? Because again, there's that thing of like, oh my gosh, I thought I was really doing well in this area, but apparently I'm not. And we've had some of those kind of epiphanies out there. I'll tell you, we got about a third of the medical schools to respond, about a third of dental schools, and about a third of the nursing schools that we sent out to, which is pretty good for a voluntary survey, but could be better. And there's this question of how do you make this a priority, and how do you get organizations to care about these things, to fill out these things, to start assessing themselves in this way. Right? And it's been a really, really interesting process, and if anybody is interested in that, that is available. But it's this movement of saying, not just let's put a spotlight and make organizations feel uncomfortable about what they're doing and the products that they're producing, right? But it's also about how do you help organizations then? What do we do next, right? And that's a lot of the work that has developed. I will tell you one other interesting development out of this. It's been 10 years since this study published, and U.S. News and World Report actually announced about a month ago that they are taking these measures and integrating it into the U.S. News and World Report rankings of the medical schools, and we're going to see if what happens with that potentially by the end of this month, the next rankings. I was at the meeting where they announced this, and it was a very interesting meeting. Having done this work in the beginning and having gone around and met a number of the deans and having, and I'm sure some of you have had conversations like this, having deans say, it's out of my control, right? This primary care issue, there's nothing I can do about it. It's all in the practice. It's all in the payment, right? It doesn't matter what I do, right? One of the things that the ranking papers showed is no, it is about what you do. I understand it's not all about what you do, but it is about what you do, right? But at this meeting, it was. I will say, in one ways, it was very gratifying to have one of the deans, the dean of the Duke School of Medicine. The diversity ranking actually is going to be a side ranking for right now. It's not going to be integrated into the full ranking. And one of her comments is diversity is absolutely a core mission of and should be a core mission of medical schools. It should be integrated now, not held off as a separate one. So it's one of those, wow, the progress that we've made over the course of 10 years. So that may be coming. We've got our fingers crossed on that one still. One other last thing I wanted to show you is graduate medical education. And you might ask, from the viewpoint of dentistry or oral health, why you should care about graduate medical education payments in the United States. How many of you know that the Medicare GME payments that go out to hospitals will support dental residency programs? Yeah. So not that many hands went up. Okay, so those dental residency programs that are out there, and I know that it's not required for dentists to do residency programs. And one of the things that we were really, really interested in at HRSA, and that they're starting, and other people are starting to do work on, is that there are residency programs that are located, generally general dentistry residency programs, and some pediatric residency programs that are starting to partner with more community-based sites, I would say. But that there are residency programs that are based, a few residency programs that are based out of community-based settings and community health centers. We funded, the two big ones that I can think of that we funded were out of the Teaching Health Center Graduate Medical Education Program, a dental residency program out of Penobscot, Maine, and the health center in Penobscot, Maine, and another one out of Yakima, Washington, and that one actually was funded both by Teaching Health Center GME as well as the primary care, that would have been postdoctoral training grant programs. And I have to tell you, one time I pulled up the Yakima Health Center website, and I was just amazed by how many dentists they have in that site, in Yakima, Washington, right? Which I'm not from Washington, and I have not been to Yakima. I've only just recently been to Seattle, but my understanding is that the state quite divides over the mountain lines, and it's very different between the two sides of the state, and that the eastern side of the state has some real challenges in terms of workforce and workforce recruitment and retention. And when I opened this health center site, I'm not even sure what I was looking for at that point, I was just amazed by the number of dentists that they have in Yakima, Washington at this community health center. So this combination of community health center as well as a potentially difficult location to recruit to. Right, and I believe that some of that is the residency program that is in that site, and is kind of based off of that whole grow your own. If you train them in the right setting, they will stay in the right setting. Not only that, but they'll have the right skill set to be able to take care of the community in that setting, right? So there are programs inside of HRSA that explicitly support those kinds of residency programs, but the biggest probably supporter of dental residency programs in the United States is likely Medicare GME. We've only just started delving into how much funding is going there, but I'll tell you, out of HRSA, the pre- and postdoctoral training grant programs are funded at I believe it's about $40 million a year right now. As we're starting to look at the Medicare data, the Medicare data going to, and one of the challenges is that dental and podiatry is reported together, so we can't separate them out. But it's very, very likely that the Medicare GME going to dental residency programs is much, much higher than the annual funding for pre- and postdoctoral dental residency program out of HRSA. So just something to think about. Medicaid programs are another big funder of GME. And Medicaid programs often just mirror the Medicare payment, which suggests that Medicaid programs in your states are likely supporting some dental residency programs as well. But just to put a little bit of numbers on the Children's Hospital GME will also support dental residency programs. And to put some numbers on that, the total amount that the U.S. government is spending on federal funding, that actually there's a little bit of, let me see what I did. So there is a little bit of state share in there as well. But the total funding that between federal and state funding that the federal government is putting into graduate medical education is about $18.6 billion annually. That is the largest investment in health workforce, in the explicit investment in health workforce in the United States. And to put a little context on that, HRSA, which includes the Bureau of Primary Health Care, Health Center, Section 330 grants to health centers, which includes the Ryan White programs for HIV, which includes the maternal child health programs and the block grant programs, which includes the entire Bureau of Health Workforce and all the workforce development programs, right? All of HRSA's annual funding is at about $11 billion. The funding that we're putting towards graduate medical education is significantly more than the funding that we're putting towards health workforce, any other health workforce development. And yet that funding is, and the way it's developed in the policies and the formulas that it's developed on ties it very, very closely to hospitals. So if you're, for dental residencies, if you're interested in moving dental residencies out into communities, right, the way that Medicare GME is established and the policies around it make it very, very challenging. And there's been a lot of discussion and recommendations that we do reform on this very big investment, because we're making a very big investment and we're not getting the workforce that we need. The other reason I also pointed out is because so much of this investment is focused on physicians. And the question is does that make sense, given where we're moving in terms of our healthcare systems, right? Given where we're moving in terms of our teams and the real needs of our communities. And I'll tell you just one last thing, one I think very, very brave thing that the VA did. The VA puts $1 billion into health professions training, graduate medical education. And a couple of years ago, they basically took a system that basically only paid and recognized based on physician resident FTE and turned it so that it was more. They didn't put more money to it, but what they did do is recognize that some of their sites were doing more or less training in some of the other health professions, and they balanced their health professions payments to recognize interprofessional training. Not that there was interprofessional training, but the full kind of range of training that their VAs were doing, and adjusted their payments to recognize that. So if there's a thought of, it's impossible, it's not impossible, the VA just did it. Right, but there is a lot of vested interest in this. As you probably all know, it's very, very hard to move money from places where it's already been, and it's been since 1965, essentially, since the beginning of the Medicare program. So, one last slide of Fitz, which was I think the really, really powerful thing of this paper that he did, this final paper that he did for academic medicine, was not only did he talk about his early years and reflect on that. He reflected on a 55-year career in this area of health workforce and health workforce equity. And one of the things that he notes is that while there has been progress, there hasn't been nearly as much progress as he would have hoped. But one of the things that over the course of a 55-year career, I think that he really recognized, and then is reflected in things like the Beyond Flexner Alliance and some of the other work that we do, is that that the focus became very much about changing the culture, about changing systems and changing policies, right? And doing work that drives those kinds of changes, right? And if you do get a chance to read the academic medicine piece, it is a little bit focused on medicine, but in the end, what it is a real charge, and it's a real final charge to say, let us hold our health professions education training programs accountable, right? In the work, in the research that we do, in the outcomes that we hold them accountable for, in the things that that's both as students, as faculty, as others, that we hold them to, that we really hold them accountable for social mission, for the products what they're producing in terms of actually addressing the high need, the needs of communities, and they can do it. It's not easy to change, it's not easy to turn, but they absolutely can do it. And that's just that final slide. I had some questions. Some things to think about. Just things that kind of draw, as we approach this, and as we approach this issue of health workforce equity, I think one of the number one questions that we're always asking is that top one. What policies and systems, and I think it's kind to just say support, but what policies and systems support health disparities and inequities, injustice, right? It's not just about how do we do more in certain areas, but how do we start to unpack some of the things that are already baked into our systems, put a spotlight on them, and push for change. And then there are some others. And a final just plug for the Beyond Flexner Alliance, which again is I think that might be very close to the National Oral Health Conference meeting. I hope we're not at the same time. Oh. 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 But it's a great opportunity. I've had the chance to review abstracts recently, and so if you are interested in health education in the pipeline, in the health education pipeline, it is people are doing just amazing things. People are really doing amazing things, and it's a really great opportunity to go to a place to see and to connect with other people who are doing amazing things and who are mission driven oftentimes in organizations, healthcare systems that we'll say that are otherwise moving slowly. So, thank you.
We have 2 microphones we're going to pass around, but I actually have 2 questions first. I can't, now it's on, sorry. Now I thought it was loud enough, my goodness, sorry, Steve. So 2 questions came via Slido, so I'm going to ask those first, okay. And then we'll walk around. There's myself and Katie over there, so just raise your hand and we'll find you. So the first question is, in the medical education social mission study, did you take into account how long they had practiced in underserved areas?
We did not. One of the things that we did do, though, is we had to wait a certain and again, you probably realize in this with the dental workforce, in the medical workforce, residency programs are required to be able to independently practice. And so one of the things that we did do, even though we didn't give them very much time beyond what we would, let me back up. Basically, we gave people enough time to do their residency programs and get out into practice because we wanted to see where people were actually practicing. One of the things that we know in medicine is that, for example, when people go into internal medicine, only about 1/3 of them actually end up in primary care. And so that we accounted for. But beyond that, there is more work to be done. It's some interesting things looking at issues of imprinting. In terms of practice patterns, one of the things that we can show is that for residency programs, based on where you practice in your residency program and the kind of practice patterns inside of that residency programs, we can then follow you out and see that it imprints a sort of cost per Medicare beneficiary. So if you trained in a place that had a lower cost per beneficiary and then you go out and practice, no matter where you go out and practice, you tend to practice in a style that is lower, and that goes on for almost 20 years. We can follow that almost 20 years out.
And I think this was more a comment, but correct me if I'm wrong. Health providers who continue to practice in HIPSAs after loan repayment / scholarship obligations would be more significant than just those who, quote unquote, practice. Okay, so I think that's just...
Yes, we agree.
Yeah, okay.
We agree. That's the like end goal of,
Okay, so question.
Good morning. Thank you. Great presentation, and we had a little time to talk. I'm Angela Filson from Mississippi, and my question is around systems. So you talked a lot about that, and I was very interested in the information you shared around social mission as it relates to medical schools. And so my question is relative to commissions on accreditation and the utilization of them as it relates to starting to look at the inequities that can be perpetuated. So, for example, many of them do require diversity training. But outside of that, is there a checklist for schools as far as making sure there are various inclusions around cultural and competent care or in healthcare settings?
Yeah.
And I think, from my initial perusal of kind of looking at their guidelines, I think that's a means that we can start.
Yeah.
Because if there's just a checklist, but there's not follow-up on a given system, then we don't really have adequate support.
I absolutely agree with you. There's so many interesting issues kind of embedded in that comment that you just made, which is one with accreditation, and we've been watching accrediting bodies start to do this, right? To build in issues of initially it was like cultural competence, right? And now we're working and moving towards health equity, diversity. There's always that question of when accrediting bodies do that, what is the accountability there? Who's going to When is a school going to lose their accreditation because they didn't address diversity, right? So that's a really interesting, or at least be cited because they're not addressing. Then the other, I think, flip issue is where do we put our investments in developing the tools to help people and organizations do this right and do this well? I think that was some of the idea behind the Social Mission Metrics Initiative project and work, but what we're finding is that so much more is needed, right? And there are organizations across, and actually one of the things that I did while I was at HRSA was we put out an award for what we called academic units, which are essentially national centers on different areas. One of the academic units is focused on this issue of diversity, and it is about both doing research that's going to drive the issue forward and put a spotlight on it, help people understand what the issues are, but then also provide tools and a community of practice by which we start to ask those really tough questions of like, what are the actual admission best practices that are going to move us towards diversity, right? What are the things that schools can and should actually be doing to be able to do those things? Now the interesting thing is whether we can continue those kinds of investments, and whether or not those investments continue is a lot about what you all demand of the resources and the decisions that organizations like HRSA and others make.
I think we have one last question. Oh, why don't we swap, Ely? I can do some ventriloquism too, probably. Here you go.
Maybe you need to do something about it.
I'll work on it.
Hi, wonderful presentation. Thank you very much. I don't think enough people die from dental diseases, so maybe we wouldn't be able to find a comparison to your primary care paper that you showed from the Annals of Internal Medicine. Are you aware of any evidence that shows that the existence of dental care providers in a certain community relates in any way to the oral health situation in that community?
Dr. Capelli looks like he has an answer. I am not aware of it. One of the interesting things is probably related to where we spend our resources, both publicly and privately. There's always a lot more research done in the physician workforce than almost any other workforce. But I think what is really interesting is that what this starts to do is really it highlights the things that we might be able to do. Every workforce is a little bit different, but I think that there's real potential, and I think that people are starting to ask those questions about what is the relationship between, for example, access to oral health care. I think that there are places that you could do it, for example, in the community health centers as a slightly smaller body once the data becomes available in other ways. And one of the exciting things, so you can kind of hear my researcher geek coming out right now, is that as some of the data becomes much more available, Medicaid data is becoming available now, we might be able to start answering some of those questions. And we should be asking and answering those questions. And does anybody else have a response to that? that we should be paying attention to? Okay, I think.
Thank you so much, Dr. Chen. We appreciate it.
Thank you.